Hi everybody, my name's Chris Clough. I'm a consultant neurologist at King's College Hospital, but for my sins, over the last 6 years, I've been chair of the National Clinical Advisory Team. I'm very sorry that I couldn't be with you today, but I'm going to give a summary of the lecture I gave to the chairs of the Senates earlier this year about Ncat's activity and what it might mean for you within the clinical Senates. Thus, I'm going to go over the background to Ncat, how it operated, and hopefully that will lead to some guidance for what you need to do within the Senates as you take over the roles and responsibilities of Ncat from April 2014. Firstly, a brief background and history. In 2006, the NHS Act said that if there was significant service change, then there should be full and proper public consultation. Sir George Alberti in 2007 put together the National Clinical Advisory Team at a time of great political disquiet and public unrest about reconfiguration of hospitals. At that time, he saw his role as mainly being a champion of change, and so got around the country to try and persuade people that there was a good clinical case for why reconfiguration was necessary. In 2008, the Department of Health decided to make this a more formal process. As it became clear, there was a requirement from the Act for independent clinical and management assessment, which Ncat would provide the clinical assurance, and the management assessment of process would be carried out by OGC Gateway, the Office of Government Commerce. Then, of course, more recently in 2010, with the coalition government, the Secretary of State said there needed to be 4 tests passed for successful reconfiguration. These were, of course, support from GP commissioners, public and patient engagement, a known and good clinical evidence base, and lastly, patient choice. Turning to Ncat roles, over the last 6 years, I've identified five clear areas where Ncat appeared to have a role. Firstly, there was the area for which we were paid for, which was the independent clinical assurance of reconfiguration. Secondly, we were often approached for early advice. This was understandable, as commissioners and providers obviously would want to pass the test that we were going to put them through, so they wanted to ensure often that Ncat approved of the direction of travel. But more than that, there was often a case to bring in new ideas and have specialist approval. This was the sort of role in the past that the colleges and specialist societies had often provided, but Ncat was seen as being more independent and not necessarily having its own agenda. So, early advice. Thirdly, we were asked to review, investigate services. It wasn't clear there was any reconfiguration. You might say, well, wasn't this a role for the CQC? But at that time, in those early days, the CQC was not particularly active, and Ncat was thought to be an easier route in terms of you only had to express some concerns rather than be aware of any concerns necessarily. Thus, medical directors might approach us to say, we're not sure there's a problem, but we'd like somebody to look at the service and tell us what's going on. Fourthly, we increasingly recognised that there needed to be a national repository of evidence. It was important that we used the same evidence bases whenever we went to see a local health economy to be sure that we were acting in a consistent manner and a fair manner to each of the health economies, and we're not being played off from one area to another to saying, well, you approved that there, why didn't you approve it here? So we began to collect evidence of good reconfiguration and look at the standards that we might apply to reconfiguration. And I would urge the clinical senates to really continue that and to apply it in a national way so that they too would not fall prey to this playing off of one senate against another. Lastly, there was Sir George's role in the first place, which I've called post hoc advocacy. And that often does occur, and I'm sure the Senates will be involved in this again. That is that you've approved of a plan, and what the local people or the local commissioners and providers want to hear is a national figure or others to say, this is good news for patients and the public, and why on earth aren't you doing it? So they want people to express that view, and of course you will meet challenges from local people, politicians and others to say, well, why have you said this? So they probably will need a continuing requirement for you to actually justify your point of view and to say to people quite clearly, these plans are good. I'll say a little bit now about our funding accountability. Whilst this might not apply directly to you in the Senate, it might give you a little bit of an idea of how the accountability has changed and how the funding stream occurred. We were initially funded by the Department of Health from 2008. This was outsourced, as the then proposals were. A lot of the activity of the Departments of Health were outsourced to the SHAs, which continued to supervise our activity till about 2013, when again our activity was then transferred to NHS England with the reorganisation. So initially our accountability was through the Finance Director of the Department of Health, subsequently to the Chief Executive of the East of England SHA, and more recently over the last year, I personally have been reporting to the Domain Lead of NHS England, Keith Willett. Overall, our costs we tried to keep down as much as we could. We did rely on on the goodwill of our clinicians, and they didn't always bill us for the work they carried out on the assumption that they were already working for the NHS, and why would they double charge? So our costs have been kept low, and I think this is important for the Senates as they go forward. There needs to be a proportionality about this process so that A, it doesn't take too many resources, too much time, and I think that would be appreciated by all those involved in reconfiguration. Thus, we paid for myself and my secretary 2 days a week, but our main cost was expenses for our visitors, of which we've got about 65. And those visitors, we still know their names and addresses, so they would be available for further help if need be in the future for the Senates. Lastly, we used to organise regular meetings, so we would have regular email contact to ensure that our members were up to date with the recent political developments or service developments. But also twice a year we would meet just to talk about our experiences and to share those and to learn from each other and to learn new things about reconfiguration. So that I think you'll find as the Senates, I would urge you to continue having something like that, because it will help you develop the assurance process of reconfiguration, because there is no one true way, and of course we can always do things better. So what did we find were the main drivers for reconfiguration? Well, contrary to usual opinion within the NHS, the clinical driver was not always of the most significant. We've been engaged in some work with the King's Fund to look at the work that Ncat has done over the last 5 or 6 years to try and learn from that and try to identify some evidence and facts that we can pass forward to the Senates. That work will be published by the NIHR later this year, so you will have available that as a source of information. Thus, it's the main reason that people were reconfiguring was indeed financial, and why shouldn't it be? I mean, trying to do things more efficiently for less money is an important driver, and we should accept that. But often it was hidden within the clinical case for change so as not to be obvious to the local population. But of course, the local people soon smell a rat. So I'd urge people to be much more open about if the driver is financial. Make sure you actually are clear about it. There's nothing wrong in trying to save money. Secondly, workforce sustainability. The need to have a sustainable workforce in emergency medicine, for instance, often means that you have to bring hospitals together. important laws such as the Work Time Directive have led to an enormous amount of reconfiguration in the health service and an enormous driver for change, and that I don't think will change in the near future, and is part of the reason now that we talk about safer hospitals being bigger, having specialist services located within bigger units with more staff so that they can carry out work safely with a sustainable workforce. Thirdly, clinical, and of course that might be because of quality issues, trying to improve quality of delivery of healthcare within a certain region, but also might be because there are safety issues, and that might have been the trigger to, for instance, I can remember local emergency medicine services within a hospital in Pontefract were delivered by junior doctors out of hours and supported by an anaesthetist who was a locum brought in from South Africa to do this. Well, these just are not sustainable, and they're not safe ways of delivering a service, and of course that would have led to change. Lastly, and this is not as frequent as you might have thought, there is the whole issue of capital estate, whether buildings are falling down, whether you need to reconfigure the buildings. That, of course, can be an important trigger for change, but in actual fact, it wasn't as common as you might imagine. So, with the King's Fund, we've been looking at our activity, and what we discovered was that over the last 6 years, we did 123 reports just regarding clinical assurance. So that was just the clinical assurance things, not the early advice. And of those, about 17 were done as desktops. In other words, the majority were done as site visits, meeting the local people and walking around the hospitals. But 17 we were able to do because there was sufficient written information as desktops. And you might want to consider that as a way of cutting down the amount of visits you do. But I say, my personal view is there is no replacement for a good visit. You get the feeling of the local people, you get the understanding of the geography, you very quickly understand how the clinical service works. So don't give up visiting, but often I think the pressure is on for you to do a desktop. Can't you just do a desktop? Well, you'll need to lay down strict rules about when you do them and when you don't do them. So that the activity varied enormously when we were getting going, up from about 6 per year, building up to about 29 in 2012. As you can see, a drop-off last year in 2013 to 10, and that was largely due to the NHS reorganisation, putting a block on a reconfiguration while the CCGs and others got their act together, and of course, largely due to the disappearance of the SHAs, who'd had an important role in overseeing the whole process of reconfiguration. And that is a role that we will sadly miss, and we'll need to build up that sort of expertise within our local action teams and CCGs. Where did we do these visits? Well, the majority were done in London. Not surprisingly, London tends to be very hot politically, and any attempt to reconfigure services in London can actually be very, very difficult. And so often we were involved with London visits. Whereas at the other end of the spectrum, if you had a chief exec who wanted to keep everything in-house, for instance, down in the southwest, SHA, we only did 2 there. So it does depend on your commissioners and SHAs, the rate of usage. But one would hope that more consistency would be given to this in future, and that the Senates would be involved across the piece wherever there is serious or reconfiguration. Who asked us? Largely it was the commissioners, as it should be, and less so the providers. But that of itself does raise a whole issue. I would say you can get away with a lot if you're a provider, and you can reconfigure your service significantly without actually notifying very many people. For instance, if you look at Bristol at the moment, a huge reconfiguration of the hospital service there, yet, as far as I'm aware, to have any clinical assurance process. Thus, the providers can get away with a lot, so you need to keep your eye on that one, and the commissioners need to be aware of what's going on locally. At the other end of the extreme, though, sometimes the commissioners perhaps were a little zealous in that they would ask us to review very simple changes, such as the closure of one mental health ward. Well, that really shouldn't be a matter for public consultation, but we have had that experience. The driver does tend to be what is the political acuity of any particular reconfiguration scheme. So if something was likely to get people marching in the streets, there would necessarily be a requirement for public consultation, and necessarily that would involve Ncat. So those could be drivers which perhaps are not pertinent always to the reconfiguration process. So what were we asked to look at? Well, we were asked to look at our whole systems in about 17 cases. So that meant reconfiguring the whole of the health services in a particular area. But the most contentious issues, not surprisingly, were about urgent and emergency care, of which we had about 31%, according to our King's Fund analysis, where we were involved in reconfiguration of urgent care services. Another area of great concern would be maternity services. So if there was any question of closing an obstetric unit or even a midwife-led birthing unit, then that may well trigger public consultation and an Ncat visit. On the other side of things, mental health, we had quite a lot of engagement with mental health reconfiguration, of which there seems to be quite a lot going on over the last few years, but it rarely had that political acuity, and there was rarely any problem with it. So a lot of reconfiguration has gone on, often under the radar in mental health, without necessarily having the same level of scrutiny. And lastly, we were involved with national projects such as the paediatric cardiac surgery, which we were asked to desktop review the findings of the review body. So, turning now to our processes, because I think you might find this helpful in the Senates as to how you actually run the actual process of clinical assurance. So this is just the bits of nuts and bolts of this. Firstly, of course, somebody has to get in contact with you to ask you to assure a reconfiguration, and that might well be the project lead. Most usually it would be the project lead, but it may well be that it's the whole issue has been prompted by important others, such as OGC Gateway, such as the SHA lead, and in future that might be the local action team, specialist commissioners, or CCG. So somebody rings you up. That then initiates a phone conversation. We ask all projects to be registered with us so that we can track them. So you need some very simple registration detail about contact numbers, nature of the project, and the state of play of the particular reconfiguration. You may wish to establish very early on terms of reference for your engagement. Now, you first need to establish, of course, what type of role you're being asked to adopt. Are we really talking about early advice, or are you actually talking about the process of clinical assurance, whereby the local providers or the local project team are being asked to jump a hurdle? So this is a test that they're going to have to either pass or fail. If it's that, then of course you need to be much more rigorous about your documentation, evidence collecting, and subsequent reports. So over the phone, I would then have a conversation with the timing of the visit. I have to say that over the last few years, we had so many rush jobs, people at the last moment thinking, oh my God, we didn't get Ncat involved, what am I going to do about it? And even in one case, I think I did flex the rules so that we actually did the visit during public consultation. This is not ideal, and hopefully over time, with the new guidance around reconfiguration, people will get the hang of this. They'll understand that Ncat needs to be involved early, that OGC Gateway needs to be involved. So let's hope that you see less of that in the future. But of course it might be a problem, And personally, I've tried to flex our activities to help the process as much as possible and not be put down arbitrary lines and say, well, you've left it too late, I'm very sorry. My view was always that this is a very difficult process, one that is very important to the NHS, and therefore our job wasn't to be obstructive, but to be helpful to the process of reconfiguration, notwithstanding the fact that we needed to apply certain standards and evidence base. So often a rush job, and that can lead to problems in finding visitors, of course, because we're talking about NHS employees who need to cancel clinics or find others to do them, and that can be very difficult. So I would ask the project team to gather together information, and that information can be quite substantial, or can be very minimal if they've gone to an outline business case, because often the outline business case will bring together all the evidence base. But what I want to see is a clinical case for change. I want to understand why the health economy is doing this. And funny enough, that often is the thing that doesn't always come out from the documentation you can read. I can remember going through hours of reading through lots of minutes and agendas from meetings, various program initiation documents, and at the end of it still asking the question, what is it you're going to do? Why are you doing it? I'm sure you will have that repeat experience. So we identified the visitors. We asked for a large amount of information, as I say, varying from PID through to OBC, but also things like minutes of meetings, rotas of workforce, have there been any deanery visits? If so, can we have the reports? Have you had any sort of serious untoward incidents? We want to see the full audit of those SUIs. So a whole raft of information which will support your visit, which must be read and looked at prior to the visit. I then tend to have a phone conference with the visitors. It's something we've initiated over the last 2 years so that we all fully understand the purpose of the visit and what we're intending to get out of it, and whether there are any little tricks to the visit or difficult personalities, for instance, that the visitors need to be aware of. So we agree an agenda for the visit and the sites of the visit and who should come to the visit. Of course, the number of sites you visit might be very important to the local people as opposed to you as visitors. So you might want to keep that in mind, because clearly if you don't visit a site, they will feel that you are damning that site unnecessarily without taking the evidence from the clinicians who were there, even though you might argue that you've seen everybody who worked at that particular site. So be careful how you identify the sites, but of course sometimes it's not even appropriate to go to the sites if it's about a local health economy, if it's about commission of health and how you're setting up the specification of the service. So the visit takes place. We normally would visit over 1 to 2 days. So this is a shorter visit than OGC Gateway, but you should take the opportunity to meet with Gateway if you can, because I always found that very useful. And it was remarkable the number of times that I met with the chair of Gateway doing their visit, and we would immediately agree on what the problem was or whether there wasn't any problem or not. Of course, remember that OGC Gateway is very much a financially systems-driven process with lots of tick boxes, which is all about whether the managerial process was the right one and whether it had actually been actioned. Whether you're asking a much more vital question in my mind which is, why are you doing this? What are you doing? And what outcomes are you hoping to see from this reconfiguration? And OGC Gateway will not necessarily make that clear within their report. So they very much appreciate us being there. And I sort of think there may well be something in the future where we carry out, or the Senates carry out their visits, much more in collaboration with OGC Gateway. Though remember, you are different, you are independent you're not a government department having to work to Treasury guidelines. So the important thing then is the report. And most of us love the work before the visit. We quite enjoy the visit, but we don't enjoy writing the report. So I would urge people to get that report down on paper as soon as you can. It's important. We set a standard of 2 weeks to get that report back to the project team. What we would do is nominate somebody to write the report. We have a template for the report which we can let you have, so it's easier to fill in the boxes and to make sure that you've covered all areas. So we want to know what the project is. We want to know the clinical case for change. We want to know what evidence you've reviewed. We want to know who you've interviewed. So all that's in the report template. So it's helpful to drive it. But ultimately, you're going to need to write a discussion about the proposals, the rights and wrongs of it, the evidence that can be sanctioned, if you like, and whether there is a clinical case for change that is met according to your criteria. So we send the report back to the project team in 2 weeks. Now, I make it very clear that's a draft report, and that is a report that can be corrected by them for errors of fact only. But of course, there is always a bit of wiggle room, isn't there, about what is fact and what is opinion. And I'm sure you'll find that some of the project teams, if they don't like what you've written, may well try to sort of twist your words. So be careful about that and be absolutely clear. It's about factual errors. You know, was it 3 doctors or 4 doctors on this particular on-call rota? Was it the size of the hospital was 850 beds rather than 750 beds? Those sorts of errors are perfectly acceptable to correct. The final report then for us would go back to the SHA. But things have changed. And of course, you are being commissioned by commissioners. So clearly the report will need to go back to the CCG or presumably the local action team where specialist services have been involved. Either way, I think you need some higher authority because there will be times when you disagree with what's been done. It's all very well if everybody agrees with what's going on and everybody's happy for things to go along. But there will be recommendations, and there will be times when you say this project should not proceed. In which case, what do you do then? And I'm going to just talk a little bit about how you might handle that. So the report goes back to the project team and the SHA, and in the past, the SHA I made responsible for ensuring that our recommendations actually took place or that at least were monitored and there was feedback. We would ask for feedback from the project teams. We were interested to know how it was for them, how did it feel like, what was their experience. But we also wanted to see what response they had to our recommendations and what actions they had taken. So, Ncat recommendations. When Ncat first started out, these could be quite vague. What we've done in the last few years is ensure that people are clear about the discussion part of the report, the conclusions they draw, and from the conclusions, what recommendations they are making. Clearly, it's important to say exactly whether the project is approved and should proceed, or whether the project should not be approved. Most usually, we would say proceed, and most usually we would say with conditions. So there would be some recommendations that would say that they should do this or do that before the project should proceed. Largely, these were around strengthening the evidence base, so we understood why we were doing the project and making sure that, for instance, the capacity within the new arrangements was sufficient for the business that was planned. You'd be amazed how often that was not done as rigorously as it might be, and to ensure that if there that it wasn't clear that there were sufficient caveats within the proposals so that if need be, further capacity could be opened up, or there could be double running costs of the old and new service. So that is always one way of ensuring that the service will continue to be safe despite the reconfiguration to the new proposals. Because as you might imagine, a lot of reconfiguration has been about how you downsize the acute services, and that will often take place if there are 2 or 3 hospitals actually move into a more acute and elective basis, with one hospital delivering the acute service, the other hospital delivering the elective services. You'll often see bed reductions grounded on the basis of increasing efficiency. Now you need to challenge that and ensure that we would not expect this to happen overnight. And most usually, project teams will use best practice guidance. So if you're talking about bed occupancy and average length of stay, this may well drive the business case and produce some very optimistic figures. Now, if that's all very well, if the service presently is living up to those sorts of standards, but of course it asks a lot of a service to move to this different practice. And as I say, you need to ensure that the patient safety is preserved, and that if there is a drop in capacity, that there's appropriate management steps built into the system to ensure that capacity can be reopened if need be. Okay. So other recommendations were often about strengthening engagement. It's amazing how often the public is kept in the dark for the early stages of the project and only brought in at a late stage, and that often makes them feel disempowered. Our recommendation is that you have patient and public involvement from the word go, so that people fully understand why you're doing this and what's the drivers for change. But so often we did find there were some problems with public engagement. Additionally, with clinical engagement. I mean, part of the purpose of Ncat visits is often for some clinicians to have a go at the management, or at us indeed, and say, well, you know, why on earth are we doing this? We shouldn't be closing this hospital. But give them their voice, and I think that's very fair. So I would always encourage the people who want to throw rocks in the pond to attend. I'd rather they came along and told us what they felt the problem was, rather than excluded from the process. So please remember that you want dissenters, as well as the people, the medical management and clinicians who are fully behind the project. So it's useful to hear dissenters, and of course it's very useful to hear the views of local GPs as to what the trust might be doing. Presentation and vision, as I've already alluded to, can be a problem for some outline business cases, that it gets so involved with the numbers and facts and figures that the overall vision, which is what the public want to hear, gets lost in the detail. So we'd often say, look, you need to just very clearly say to the public why on earth you're doing this and why they're going to get a better health service out of it. So if that's about saving money, well, you're going to reinvest that money in community services so that you have better access to your local services. But it may well mean that, unfortunately, that we can't all have an acute hospital at the end of the street. That is the balance. That is the way things are going. And we have always strongly supported schemes where it is clear that the overall quality of care will be better, even though it might mean that sometimes access to acute hospitals in terms of geography diminishes. Lastly, we have made comment about project management. And of course, in these difficult times over the last 5 or 6 years, what we witnessed is that project management from top to bottom has its deficiencies. We would say that the best way to make sure that reconfiguration happens is ensure that you've got top leadership fully engaged early and all agreeing on the direction of travel. So they all need to sit in the same room, commissioners, providers, the local people. There need to be actually a top board, if you like, a project board which actually oversees the project from start to end. And sometimes that doesn't happen. Then you need project managers who are trained to do the job. And we often saw project managers who really had been, the project had been dropped on them in the last minute. Oh, just go and do this for us, will you? Without having the experience and the time and the resources to deliver what often is a very, very difficult process. So if you want to be successful in reconfiguration, persistence is all, but you've got to put in the resources and have those planned accordingly. So proceed with conditions, but also there will be times when, unfortunately this was rare, where you said not to proceed. You should not go to public consultation on these proposals. In that case, I'd be on the phone straight away to the SHA and say, look, this is what my visitors are saying, or what I'm saying, and we need to actually have a process of arbitration, or at least people need to understand what's been said here. Clearly, we are an advisory body, but of course it would be very foolish for a project team to ignore the advice of a national body, and I presume to ignore the advice of the Senate. Having said that, of course, our visitors may not have completely understood the project. They may not have got the point of it all, and there may be some misunderstandings that need to be hammered out. So getting everybody in a room together, understanding what the Ncat's or the Senate's problems are with the proposals, and coming out with a jointly agreed way forward may well be the best way to deal with this. I don't think it's sufficient just to drop a report on somebody's head and say, look, we don't agree, end of story. I think it is actually much more about engagement and understanding how you make a way forward. And I think that would be appreciated by all if that's the stance you took. We've had a couple of famously instances where the Ncat did put a stop to things, new hospitals which we couldn't understand why they were needed, and on the South Coast certainly problems with maternity and paediatric services which were clearly not safe. So what happened next? So in other words, you've visited, you've given your recommendations. Did anything happen to these? Well, the first thing to say that in our own case, about 40% of the proposals we'd interviewed and looked at were not implemented. Now, many of those, one would hope, are still works in progress. Reconfiguration is a long and difficult road. So it may well be that there are still people working on these proposals as we speak to make sure they happen. But clearly, some proposals are abandoned, and it might not be because they've had a bad Ncat report, but more likely to be for all sorts of reasons. The main reason be the constant pace of change of NHS management, lack of interest at a top level, all sorts of reasons why projects get abandoned. But of course, new commissioners with new priorities, and they may not regard these, the reconfiguration as being a priority. And of course, local patient and political uproar. Marching in the streets is a way of certainly making a difference, and it will actually get the Secretary of State interested, and that may put a stop to reconfiguration in its tracks. So that for all sorts of reasons then, and it's a point I want to make here, is that you should view reconfiguration as being a complex, difficult process with changeable outcomes. And it doesn't necessarily have a beginning and an end. It may just be an onward going process. And of course, during that lengthy time, new things happen. There are new ways of doing things. Look at the way we now manage coronary artery disease, for instance. You know, we probably wouldn't have envisaged that 10, 15 years ago, but all of a sudden it's made a huge difference to how we configure the processes. If this had come in at a time when we were building new coronary care units, we might have had to think very differently about how those units were reconfigured. So I just wanted to say a few things about important others. These are the important partners we've had over the years, and I'm sure it'll be the same for you in the Senates. Clearly, patients and the public are very important partners to any reconfiguration process. And I can't stress that enough. When we visit, we always talk to the local patient groups, public groups. We always try to get hold of the OSCs and representatives of patients and the public. I was very keen for patients to be involved, or the public to be involved, in the Ncat visits themselves, so on the other side of the desk. But it was felt, certainly by the Department of Health at one stage, that this was about clinical advice, not necessarily a requirement for lay involvement. Personally, I disagree with that. I think it's always helpful to have people from the public involved, and I would urge the Senate to consider that and to consider whether they should always have a member of the public involved with their visits. And of course, you can invite people with terrific skills, other skills, to enhance that process. Secondly, the IRP, the Independent Reconfiguration Panel. Now, of course, the IRP gets involved if somebody cries foul, and anybody can cry foul at any stage. And of course, if that ends up on the Secretary of State's desk, then the Secretary of State is going to turn to the IRP and say, please sort this out for us. We want you to go and carry out a visit. So although we're doing roughly the same sorts of things, the IRP and Ncat, I would view Ncat as trying to prevent the IRP getting involved. So I'd hope you would see a role in similar way, that the Senate should be seeing that seeing the IRP get involved almost sort of spells a feeling of failure. But I'm afraid it happens, and it happens for all sorts of reasons, and they're not always predictable or preventable. So we have good relationships with the IRP. I personally meet with the Chief Exec and the Chair from time to time, just to make sure that we're talking roughly from the same hymn sheet. Clearly, if they're operating to a different evidence base than we are, then there's going to be a problem, and I'd urge you to keep those contacts in place. Secondly, I've made a case for keeping involved with OGC Gateway, and there may be a facility here for increasing cooperation. But as I said, remember, Gateway is a different organisation. It is a government body, and it is about process. So you will always have your role different from there. We've made contact over the years with the Competition and Cooperation Board, and that, of course, becomes important if there are elements of competition that you're unhappy with. And I think they were very interested to hear of our experience. For instance, sometimes you're asked not to actually look at the sites, but to look at the specification of a service. So how you specify. I can remember in Sheffield, we looked at the integrated care plans. This was a specification for a service. We were then invited back to judge the tenders for that service. So I think that was a very good process. But of course, a specification can be written so as to be counter competition, so that it actually favours one particular group rather than another, if there caveats are placed in that to make it clear that you're looking for a specific provider. So you need to be aware of that ability, particularly with the involvement of the CCGs, where we have had instances where clearly the only provider of that particular service could be the local GPs. And so that may be a requirement for involvement of the competition board. Over the years, we've had good relationships with the medical panel of the CQC, less so since the CQC became more grand and bigger and of course now involved with hospital inspection. So, but in its early days, certainly if I had any concerns about patient safety, I always felt I could ring the medical director of the CQC for advice and guidance. It didn't happen that frequently. But also, I think there's a broader issue about our engagement with CQC. Again, if we're using different standards and different evidence base, then we've got a problem. So we need to be sure that both organisations, the Senates and CQC, do share the same evidence base. I have raised this with the Chief Exec of CQC. Thus far, no response from him. He's probably a very busy man. But I think it will be a continuing concern, because if we are working to different evidence bases, then there will be difficulties in, and appeals will come forward. I worked very closely with the Department of Health at one point, and then with NHS England, particularly the National Clinical Directors. And I think you should see these as a resource. They're perhaps not as potent as they used to be, and there are more of them, but they can still actually guide you about visitors. So I've, in particular in child health and maternity, had a lot of help from the NCDs. And of course, they can guide you about policy direction. And so although you're independent, you need to be aware of the sea that you're swimming. And so I found the NCDs very helpful. As I was a lead myself for neurosciences, I guess it was easier for me to make contact with them. But I've no doubt that they would appreciate your collaboration. Colleges and specialty societies, yes, again with certain caveats, we've been very helpful. We've been involved with drawing up guidance for maternity services, and the college, with the College of Midwives, has been very helpful in guiding us with that. And of course, they're a very good source of getting potent visitors. You know, it's, an ex-president of the college may have his drawbacks or her drawbacks, but they can be quite powerful people, and they can speak with authority, and that can be very useful. So I find them very helpful, but of course you need to be clear with any college representation that they're doing the visit on your behalf according to your rules and regulations, if you like. And you need to be clear about that. I did have one college say, well, we're going to charge you, have a charge out rate for this, on the grounds that these are our people, and we'll charge you £20,000 if you want to use them. I'd be aware of that one. I nipped that one in the bud and said, well, I'll just go straight to the person and ask them, and I'll not only get a much better rate, but I want them to be independent, autonomous visitors. I don't want them to be there at your behest. They're not your representative. They're not there to do your job. So yes, be careful. And of course, then there's a whole string of people I've listed here, relationships with purchasers and providers, local health and wellbeing boards, OSCs, patient forums and charities. Local groups care passionately about their local health services. And so when they hear about change and they hear that somebody, you know, from London, my goodness, is coming to look at their health services, they are very interested and want in on that visit. And if they're not in on the visit, and excluded, they will then come back and try and button you later. I've got no problem with that, and we'll deal with it, but clearly some of the time you need to direct them appropriately, because they may well be asking you questions that you can't answer, and you need to be clear with them that your role of assurance. You're not there to design the health services, which is what they often think. You're there to say whether this makes sense from a clinical perspective, and will it provide a safe, durable, sustainable service into the future of high quality. That's what you're there for, so you need to be clear with them. But that brings me to politicians, because inevitably politicians do get involved. I found myself sitting in the local Northallerton Town Council while I was grilled by a lot of nice Yorkshiremen in flat caps. No, I'm just joking there, but about their local services. And it was an interesting experience, and I think you'll find yourselves drawn into that. And personally, I think that's what you're there for. We need to explain, we need to actually say why these changes are for the better. That's what they want to hear. But of course, these will be very passionate people who will be more knowledgeable than you are about local services. They'll have the history of the last 50 years of health services in wherever, and will be able to argue their case very effectively. So do be careful that you're clear, you're sure of your facts. And then, of course, the local MPs often do get involved, understandably, because local people will present those problems to them, and they will see themselves as advocates of the local population. And, of course, there are votes in it, as ever with local MPs. But you may be asked to respond to local MPs. Personally, here in London, I'm able to get down to the House of Commons and see them if need be and talk to them, and I haven't had any difficulty with it. I think it's a useful role again, because largely you'll be saying this is the decision that's been made by the local health economy. We support it for these reasons. We think it makes sense. We think local politicians should support it and not actually engage in drumming up public support merely for the production of votes. Well, you're better than a man than I am going it in. You're able to make that point. Okay, so lastly, so I think I'm finishing here. My conclusions from this talk about the Ncat and how you need to, as Senates, draw on some of those roles and responsibilities to take them over from the April the 1st. I hope it's been helpful in explaining a bit about the background, about the process, some of the pitfalls and how you might go about the process. I personally do think that clinical assurance can and will add value, but it needs to be done not necessarily in an exam forum, although inevitably this process will be seen as a jump to be jumped, but it needs to be in a supportive way, and you will meet some people who will try to steamroll you, particularly powerful chief execs. So you do need to act with authority and be sure of your evidence base. Personally, I think you need to ensure that your process is external, so that any perceived conflicts of interest are reduced as much as possible. Although I was once told when I was visiting the hospital in West Brom that I must be biased because I did a clinic there in 1978 as an SHO. Well, of course, that we were able to dismiss that one as being a valid point, but people will seek to see whether you do have conflicts of interest. So do ensure that it's external. And one of the things I've suggested is that perhaps in certain cases that you may wish to involve your next door neighbour or a far distant Senate to carry out the clinical assurance process on your behalf to preserve that externality. Secondly, you need to be seen to be independent. Now, of course, you are acting as Senates within the health service, so of course you are health service employees, so that the level of independence is a sliding scale, of course. So it is a mindset that you must adopt. And of course, it's important to be authoritative and to be evidence-based. I think one of the failings, if I look back over the reports that we've issued from Ncat, is that we didn't always put in the audit trail for the evidence. So we spoke from authority in the knowledge of the evidence, but we didn't source it or audit trail it so that people could follow through our conclusions in a logical sequence. So if you could learn from that and build in your audit trail from the word go, I think that would be important. Lastly, as I've mentioned, I think any regulation process needs to be proportionate. And so the word there should be, it needs to be of low cost. It needs to be timely, so you don't get in the way of reconfiguration. These project teams are often very time pressured and are looking for decisions to be made quickly. And I do think it needs to support the process. That I think is an important part of this, as well as, of course, making sure that you do act to validate the process. And I forgot to mention something there. Often your role can be to actually suggest different processes and to actually sort things out. For instance, a lot of doctors and clinicians may have really good information about how you actually do meet some of the challenges of providing 24/7 services in the specialties by different workforce, rostering by building up the skills and profile of the whole workforce rather than just individual members. So you may well have a lot to give the local commissioners, and you may not recognise that that is actually what they're seeking.